Society for the Study of Pain was established, and this is the Foundation Day. So on this Foundation Day, we have taken an initiative from WBSSP, West Bengal Society from the Study of Pain, for a social awareness program on fibromyalgia. So many dignitaries, experts from various parts of this world, India and abroad, has joined and are going to join this program today on this online platform. And we also circulated this as it is a social program. So many people from the community are present today and will be following this program on the Facebook Live and YouTube. So on behalf of WBSSP, I welcome you all. Let's join hand in hand to know about the fibromyalgia, its causes, and how to treat, and what are the modalities of treatment on this. So many people are suffering from this. So let's start this program. We have here to moderate this program Dr. Sanjay Patwari. He is a senior pain consultant and anesthesiologist, and Dr. Vaibhav Vandari. He is also senior and pain consultant from AIIMS Rishikesh. They will moderate the whole scientific session.
Would you please
So
check my YouTube stream
I would request Dr. Pravesh Kante. He is the National Secretary of ISSP. He will give some. He will talk about something to us. So, Dr. Vaibhav, Dr. Pravesh has not yet joined. So I think we should move on to the scientific program. Later, when he will join, he will give some notes for WBSSP.
Okay, fair enough. So I would like to invite our first speaker, Dr. Debanjali Ray. She has been associated with ESI Institute of Pain Management. She was ex-fellow of ESI Institute of Pain Management. Then she practiced as consultant pain medicine in Apollo. Then she's right now in Australia. She's a fellow of Australian College of Anesthesia and Pain, and right now she's acting as senior registrar in Department of Anesthesia and Pain in Alice Springs Hospital. Her main area of work is on pain, and she is actively participating on a study on fibromyalgia, which is run and funded by Alice Springs Hospital. So I take this opportunity to welcome Dr. Debanjali. Dr. Debanjali, you're most welcome.
Okay. Hello, everybody. I'm extremely sorry for my bad voice. I've got a very bad sore throat, chill, rigor. I was not sure that whether I would be able to join, but for you guys, I'm joining because I don't get frequent chance to talk to you, visit you, to see you, have a chat with you. So somehow I managed. So my voice will be a little lower. If I'm not audible, just let me know. Okay. So when when I was treating fibromyalgia in India, the concept was a bit different than what I am doing here now in Australia. Okay, in Australia, three types of physicians usually treat fibromyalgia. Number one is family physician, which is run by the Royal College of General Practitioner Australia, and then the pain physician and the rheumatologist, right? And the it's as it is an awareness program, so I would like to focus how the fibromyalgia patients usually present and unusually present as well, because it's a very difficult to diagnose initially, and it has been seen that after 3-4 months the patient is coming to the pain clinic with the fibromyalgia because she was or he was directed to some other clinics for getting other treatments for some other complaints. So there is a fixed standard diagnostic criteria by the American Rheumatology Association. I'm not going to mention that into the details. Just uh, two, three things. Uh, it is very easy to miss the diagnosis of fibromyalgia on the first occasion because reaching to the diagnosis of fibromyalgia or watching a patient of fibromyalgia is like four blind person watching an elephant. Okay, somebody is touching the leg and the patient is saying it's like that. Somebody touching the nose, the trunk, somebody is touching the teeth. It's that like that only. So overall, and it's mainly based on history and clinical assessment here. We don't just jump to the laboratory investigations in very first day. And but why there is a chance of misdiagnosis or not getting into the diagnosis quickly? Because most many of the fibromyalgias are associated with the rheumatoid arthritis, right? So they are getting treated with the rheumatoid arthritis. They are also trying to manage the fibromyalgia, but more focus is on joint pain, swelling, and morning rigidity, and that's one cause. By that time, the patient has cured all those things. The muscle pain has developed a lot. Number two is if there isn't, because there are a lot of variations in presentations of fibromyalgia, some patients come with tenderness of joint and swelling, particularly in one joint. Every possibility of sending the patient to orthopedic clinic. Okay, you have got some septic arthritis, go there, get treated. If not, we'll see. This is another chance of misdiagnosis. And I have seen many patients here presenting as CRPS like feature. I have got a patient, Ferimond Mo. She was getting treatment for orthopedics clinic, general practitioner, everybody treated, and everybody has written the diagnosis CRPS. Ultimately, when the patient was sent to my clinic, I saw the feature of CRPS is not as much as her muscle pain is. Okay, so they are just focusing on the excessive skin color changes and all that, which is occasionally once or twice in a year, but the muscle pain is constantly throughout the year. So there is another chance if the patient presents like that, there's a chance of misdiagnosis. And ultimately, taking history, why this, I have found that Pheromone Mo has post-traumatic stress disorder due to some disharmony between her parents. So if patient comes with psychological problems as well, like anxiety, I'm very much tired but unable to sleep, so these are also to be taken care of slowly. Before sending him to the another clinic, just ask 3 4 questions like, do you have muscle pain with that? Are you unable to concentrate on what you are doing? Do you have got any joint pain like that? So if we do this, then there is less chance of missing the diagnosis, and it would be earlier to reach to the fibromyalgia diagnosis. And another thing is what we say, check your thyroid level. Frequently we say, check your TSH. You are getting muscle pain. You are getting carpal tunnel syndrome. Check your TSH. Even if it is there, hypothyroidism causes less fibromyalgia than hyperthyroidism. So there were several studies which proved that fibromyalgia is more in hyperthyroid patient than in hypothyroid patient. So treat thyroid. Definitely you have to treat that. But at the same time, don't just say that you have got thyroid, that's why you have got fibromyalgia. Yeah. Okay. And lastly, I would like to mention about some atypical presentation. Like one patient came to our clinic, and also same kind of patient came to Adelaide because one of the pain physicians from Adelaide comes to our hospital twice in a month for doing the study and seeing the patient. So we have got two patients who came first with the pain during toilet. Definitely, we thought about UTI. We sent her to the scopist for the colonoscopy. Please check if there is any. We sent a lot of investigations, ultrasound, KUB, etc., etc. Ultimately, it turned to chronic pelvic pain, and ultimately it turned to fibromyalgia. And now the patient is getting the desensitization therapy in our hospital. So this is one of the atypical presentation. Another presentation we usually got around 55 to 65 years age group, like atypical depression and melancholy. Patient says, "What if I ask, what's your problem? What's wrong with you? Where is your pain?" Nothing is there in the world. The world will be destroyed. Like melancholy. There are some totally some talks that we should be spoken in a psychiatric clinic, not to us, but patient starts with that. This melancholy is due to disturbed sleep for a long time because patient is restless from inside. There is serotonin, noradrenaline, all are depressed. Dopamine is high. That's why this melancholy. This is another atypical presentation. And one of my other patients came with trigeminal neuralgia, typical trigeminal neuralgia, did everything, whatever we could do. This pain gone. Ultimately developed fibromyalgia because chronic depression due to the this trigeminal neuralgia. So in this way, we just take records, we try to manage accordingly. And in Australia, because the first Australians are the indigenous people, not the British one. So here the study will say something different than the other people we see, the white people we see in the world, because the indigenous people has got very altered body ratio, like their upper segment is too big, too heavy, but they have got too tiny and narrow legs. They just can't bear the weight of the upper segment of the body, but they come with, usually they come with low back pain. We try to treat accordingly. Low back pain, okay, but ultimately it has been seen nothing in the MRI, nothing. So many patients, if I give like mirtazapine or tricyclic antidepressant, is it going to give me a lot of sleep in the morning? Yes, my dear, it will. But ultimately, it will cure your pain as well. So you need to counsel the patient. Don't just straightway go to the pharmacy, show the prescription and ask, ओ भैया ये मुझे क्या सुबह में बहुत नींद खुलने में देरी हो जाएगा, तो वो लोग तो बोलेंगे हाँ 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 हाँ, but you have to make sure that patient is taking, maybe you can start with low dose, you can counsel, and also the survival strategy you have to teach them with the mindfulness. I know there are a lot of people's experts here, so I think I will stop here. Okay, thank you very much for your patience.
Thank you,
Thank you,
Devanjali, for your
Devanjali, for
excellent
your excellent
presentation.
presentation.
Thank you
Am I
very,
audible?
Am I audible? Yeah.
Yeah.
yeah, you are
Yeah.
audible.
So I would,
So I would,
because I
because
think
I
you are
think
not
you are
keeping
not
well,
keeping
so
well,
I
so
won't
I won't
engage you
engage
much.
you much.
I
Yeah,
would
yeah,
I
rather
would
switch
rather
to the
to the
other
other
yes,
uh,
faculty
mm,
or
faculty
the,
or
the
the
dignitaries from
dignitaries
various
from
streams
various
yes,
that we
streams that
have
we have
along with here.
along with here.
I would
I
request
would request
Weber.
Weber.
So please
So
go
please
ahead.
go
I'm
ahead. I'm
just having
just
some
having
difficulty
some
with the
difficulty with
hardware.
the hardware.
Weber, please.
Weber, please.
Okay, so we have here with us Dr. Abel Lawrence. Uh, it is my great pleasure to introduce him to you. He's an expert in the field of fibromyalgia with an extensive background in rheumatology. He's a professor in Sanjay Gandhi Institute of Postgraduate Institute, and he has dedicated his career to understanding and elevating complexities of fibromyalgia. Uh, he's passionate and he's advocate for patient education and support. So, over to Dr. Abel Lawrence.
Dr. Lawrence,
Dr.
please
Lawrence,
unmute
please
yourself.
unmute yourself. Good evening, everyone. My journey into fibromyalgia is an interesting one. When I was training as a rheumatologist in Sanjay Gandhi Postgraduate Institute, we were interested in inflammatory or serious rheumatic diseases, as if the disease like rheumatoid arthritis, lupus, etc., are the only ones we should be interested in, whereas fibromyalgia, nothing happens to them. So we ignored it, and in fact, without even looking hard at it, we used to totally ignore that. But once I reached, once I left SGPJ and started practicing in Amrita Institute of Medical Sciences, Cochin, I used to get patients who come from UK, many of the UK. That is, they get an appointment for a rheumatologist after 1 year. Then they come fly to India and then come to then you tell them that they don't have any arthritis, lupus. Then they will tell me, why do I have pain? Doctor, I came all the way from London to spend so much money. Now tell me why I have pain. So this basically forced me to confront the problems of fibromyalgia, hypermobility, and such diseases. And by interacting with patients and studying, that's how I learned fibromyalgia. And over a period of time, my concepts of fibromyalgia also evolved, including in the beginning, I used to use the old 1990 criteria for diagnosis of fibromyalgia. And what I learned is that there are a lot of reasons why people misdiagnose. That is, to apply 1990 criteria, you have to practice hard, systematically, the technique, not only the technique of examining gender points, but also explaining to the patients. And most of and when I've trained my students, what I realized is that the commonest mistake is not explaining correctly to the patients, not verifying the patients have understood it. So it's a very demanding thing to examine fibromyalgia compared to other diseases. And then later on, when the new criteria, 2016 criteria came, I found that most of these patients with 2016 criteria, had all these comorbidities. Many of them had chronic fatigue syndrome, restless syndrome, post-traumatic stress disorder. All these things were much more common. So basically, I was thinking, hey, are we diagnosing fibromyalgia or are we diagnosing something else? So with my student Sakir, we did this study to try to validate. And what we found was that these two diseases, basically the two criteria, basically were picking up two different things with a considerable overlap. They're not exactly the same thing. And then during this period, I used to correspond with Fred. So I became a big critic of the new criteria. Is this really the fibromyalgia we're dealing with? And then I confronted Fred Wolf. The Fred Wolf is the only common author between the 1990 and the 2016 criteria. So you can say fibromyalgia, this is his life's work. So what he explained to me was that the original concept of fibromyalgia before the 1990 was that it was a multi-system disease. It's a multi-domain disease which affects all these things. So the fatigue, disturbed sleep, cognitive dysfunction, the somatic symptoms, and all of these things were actually part of the original thing. And the 1990 criteria actually, made it possible for people to ignore this. So part of the reason for the adoption of the new criteria was to force people to look at it holistically. And then along with this, the concept of central sensitization syndrome, all these together. So, and second reason was that fibromyalgia, as Dr. Ray said, different people blind men are describing it differently. Different people are describing fibromyalgia by different names. And so this kind of a new 2016 assessment basically forces you to look at it in a multidimensional way and bring it together. However, what we see is that neither of these criteria are actually comprehensive, and using only one of them can lead to missing patients. And so basically, if you're an expert who sees fibromyalgia patients, you have to use both of them. And another thing is that regarding comorbidities, that what I found is that most patients with fibromyalgia have some comorbidity. So diagnosis of fibromyalgia is only the beginning of the patient's quest. That is, if you have fibromyalgia, most patients have something else along with that. The question is, have you identified it? And whereas on the other hand, if you have some other disease, rheumatoid arthritis or any other disease, they can also have fibromyalgia. So the question comes, how much of it is fibromyalgia, how much of it is the other disease? So unless you are good at assessing fibromyalgia, since there are no blood tests for diagnosis fibromyalgia, you have to spend time and evaluate the patient through a systematic and structured history taking and exam and evaluation. And then you can see how much of the problem is fibromyalgia, how much is the other disease. But in some conditions, like if you have a rheumatoid arthritis patient, if the number of tender joints far exceeds the number of swollen joints, you should be considering fibromyalgia. But that will depend on how good your examination of the joint is, how is your accuracy in classifying a patient joint as swollen. So the clinical skills are much more important in fibromyalgia than in other diseases. If you don't have fibromyalgia, just counting the number of painful joints may be enough. But in fibromyalgia, when you have comorbid fibromyalgia, it taxes, it stresses the limits of our clinical skills. So for a physician, it is very important that every patient should be assessed for fibromyalgia. And it is very easy. The simplest definition of fibromyalgia is widespread and persistent pain. If you don't have widespread and persistent pain, you don't have fibromyalgia. So if you remember, if a doctor remembers this, it is easy to rule out fibromyalgia. Widespread means, widespread is very well defined in this criteria. Different, in fact, the 1990 criteria, 2016 criteria, the American Pain Society, they all have different definitions of widespread pain. But still, the idea is that to label somebody as fibromyalgia, the pain has to be widespread. And another important thing to recognize is that pain in fibromyalgia is persistent, which is not given in the criteria, but persistent pain is another characteristic of fibromyalgia. If it is due to other, say, like if you have pain due to, say, hypermobility, pain is intermittent. That is, non-fibromyalgia pain, patient is pain-free sometime. Whereas in the case of fibromyalgia, there is always some pain. So if you ask these the questions, do you have pain all the time? Do you have pain all over or most of the places? So if you, by looking at the simple question, whether you have widespread and peripheral pain and persistent pain, you can actually exclude fibromyalgia without going through. If you have persistent or widespread pain, then you should go through the whole, protocol of evaluating for fibromyalgia. And I recommend that both the 1990 and 26 criteria you should be used. And if you have interest in fibromyalgia, you have to take effort to learn tender points, even though many people think that this is not obsolete. And in our experience, the patient with 1990 and 2016, most patients have fulfilled both. But there is significant numbers of patients who fulfill only one of the criteria, and they may be biologically different from others. What about the patients? Diagnosis of fibromyalgia for patients actually reduces their expenditure, reduces their stress. In fact, depression, every patient with chronic disease, 60% of the patient with chronic disease have depression. Why? Because they're stressed, chronically stressed. And what more stress can you have if the doctors cannot identify? They have all these symptoms, they're going from doctor to doctor, tests are not finding anything, or sometimes you have some false tests which sends you on a wild goose chase, and you are prescribed all these so much of medicines, and then sometimes even opioids, and all these create more. In fact, opioid is something you should not use in fibromyalgia because opioid pathways are overactive, and the descending nociceptive inhibitory pathways through which opioids act actually is flipped. That is, activation of that pathway increases pain in fibromyalgia, as shown by naltrexone studies, which actually, in fact, if you block opioids, pain improves. So recognition of fibromyalgia actually reduces cost and brings reassurance, reduces stress, and at least removes one of the exacerbating factors in fibromyalgia. Second, every patient of fibromyalgia needs to be evaluated comorbidity, and about 25% of patients who have PTSD. It's one of the common psychiatric comorbidities. And patients with PTSD there may PTSD with fibromyalgia, PTSD without fibromyalgia. In fact, what if you take the natural history? PTSD begins within 6 months of the insult. That is, if you have a stressful event, if it doesn't happen with 6 months, it's not PTSD. You can't classify it. But over time, these PTSD patients become fibromyalgia. So much so, there is a term post-traumatic fibromyalgia syndrome. So in US Army veterans, after the training, before they went to war, a lot of them had PTSD. But when they came back, the amount of PTSD remained the same, but number of fibromyalgia increased. So fibromyalgia is a later result of PTSD. Similarly, CRPS. Some of the patients with CRPS they eventually become initially when you have positive symptoms, the swellings and all these things, you can diagnose CRPS. And over a period of time, these positive symptoms of CRPS disappear, and what they are left with something which is indistinguishable from fibromyalgia. So the thing is, presence of one diagnosis doesn't exclude fibromyalgia. Presence of fibromyalgia doesn't exclude other diagnoses. So the point is that fibromyalgia is not one disease. It's an end result of many conditions. And another very important comorbidity we need to consider is obstructive sleep apnea. More than 50% of patients have snoring, and people with 80% of patients with obstructive sleep apnea have some form of pain. So OSA leads to significant sympathetic overactivity, and this hypoxia, all of these contributes to development of pain in obstructive sleep apnea. And it is one of the important things you can target. In fact, if you find a comorbidity, treating that comorbidity actually improves fibromyalgia. So there is only so much you can do about, number of treatments for fibromyalgia are limited. We have given pregabalin, duloxetine, all these things here. So basically losing weight, if you're overweight, losing weight, controlling metabolic syndrome. In fact, diabetes and HbA1c correlates to tender points. So the thing is, even metabolic syndrome, this obstructive sleep apnea, all of these comorbidities contribute to the pain. So managing fibromyalgia means recognizing as many comorbidities as possible and managing those comorbidities. Similarly, if you have rheumatoid arthritis and fibromyalgia, you control the rheumatoid arthritis disease activity well, the fibromyalgia pain comes down. But if you don't treat the fibromyalgia and treat only the rheumatoid arthritis may come down, but the pain doesn't improve. Patient thinks disease is not better. Patient stops the medicine, keeps changing doctors, and then arthritis doesn't improve. I've seen patients going around from doctor to doctor, changing medicine too frequently, so that the effect of arthritis treatment is not effective, whereas the problems are due to the comorbidity. So treating comorbidity of fibromyalgia is essential for the patient to feel that they are improved. Because whatever disease you have, patient goes to the doctor because they have pain. And if you don't manage the pain, they will change the doctor. So for both the doctor and the patient, recognition of fibromyalgia is very important. Similarly, recognizing comorbidities in fibromyalgia is also important. And another challenge we have is that many doctors even today think that fibromyalgia is not a real. Small fiber neuropathy. But that does not mean that small fiber neuropathy is causing fibromyalgia. In fact, this pain itself can cause small fiber neuropathy. So I don't want to, there are public also here. I can go on for 1 hour about what are the kind of abnormalities which are detected in fibromyalgia. And what we are doing today now, what we have found is that, again, fibromyalgia is not one disease and more than one pathway is involved. And in addition, the people talk about central sensitization, but pain researchers have found that the concept of central sensitization actually doesn't exist. There's no evidence for central sensitization unless you induce something. If you can do some genetic manipulation and spontaneously, there is no central sensitization. It's not possible. So what I feel is that what we have is central disinhibition. There are pathways that inhibit pain and inflammation and rather neuroinflammatory pain, and these are defective in fibromyalgia. And so large swath of patients have loss of this. This is the clue. So, and the inhibitory pathway is oxytocin. In fact, hypothalamic oxytocinergic neurons innervate all across the brain and into the spinal cord, and they inhibit pain. So if you have loss of oxytocin coming from the hypothalamus, this inhibition, loss of this inhibition leads to pain. And so this is, but not all patients. And many patients also, we have found is that, especially male patients who have dorsal, that is polymorphism, that is gain of function polymorphisms in the NAV 1.7 sodium channel, which leads to increased pain transmission. So you have both a loss of central inhibition, also increased peripheral signaling. So this is a very complex disease, and progress will be made, and I'm sure in the next 5 years you'll have better treatments. But our job as people who treat patients with fibromyalgia is that we should be looking for comorbidities in every patient with fibromyalgia.
Thank you, sir, for your. Yeah. Just a moment. Hello.
Hello.
Vaibhav. Yeah. Sorry, I am having some issues. Would you please sum up Dr. Devanjali and Dr.
had to say?
Thank you, sir. Thank you, Dr. Abel, sir. That was
And I would
prefer if you can do it in Hindi so that
our
our audience can also understand
what has
been discussed.
okay, fine. थैंक यू सर, थैंक यू एबल सर का बहुत बहुत धन्यवाद, और डॉक्टर देवांजलि का भी। तो फाइब्रोमाइल्जिया एक ऐसी डिसीज कंडीशन है जो बहुत सारे डिसीज के साथ में एग्जिस्ट कर सकती है। ये डायग्नोसिस, पहली बार पेशेंट इधर उधर जाता है, डायग्नोसिस इज़ वेरी डिफ़िकल्ट। देर आर सर्टेन मतलब डायग्नोस्टिक क्राइटेरियाज हैं, 1999 का है, 2016 का है। डॉक्टर एबल ने जो एक कॉमन लिंक है इन दोनों डायग्नोस्टिक क्राइटेरिया, डॉक्टर वुल्फ उनके साथ काम किया हुआ है। तो ये बता रहे हैं कि बहुत सारे पेशेंट ऐसे होते हैं जो किसी या तो दोनों क्राइटेरिया में फिट होते हैं, या बहुत सारे पेशेंट ऐसे होते हैं जो किसी एक क्राइटेरिया में फिट होते हैं। तो ये पेशेंट सही में बार बार डॉक्टर्स के पास बदलते हैं। इनकी मेन जो दिक्कत होती है पेन होता है, इसके साथ साथ ये डिप्रेशन से भी जूझते हैं। तो हमारा मेन एम जो है, पहले इनका जो है पेन, हमारा पेन को एड्रेस करना चाहिए, और फिर धीरे 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 हर एक सिम्टम्स को एड्रेस करना चाहिए। डिप्रेशन में भी कुछ जो पेशेंट है, डॉक्टर एबल ने बताया, वो पोस्ट ट्रॉमेटिक स्ट्रेस डिसऑर्डर भी रहता है उनमें। तो पोस्ट ट्रॉमेटिक स्ट्रेस डिसऑर्डर के साथ ये को एग्जिस्ट करता है, जैसा कि उन्होंने बताया कि यूएस के बहुत सारे आर्मी वेटरन्स में बहुत कॉमनली देखा जाता है। तो I think Sanjay sir, we should invite our next panelist.
But before that, I will also, since because we are doing it from Kolkata, West Bengal, so I would request Devalina, if she is there, to also sum it up in Bengal in a very short, before we move on to the next speaker.
ফাইব্রোমাইলজিয়া যেটা
আমাদের দুজন একজন প্রফেসর এবং
our
next
audience would
audience would
excuse
excuse
us
us
for
for
a
a
short
short
period
period
since
since
Devolina will
Devolina will
explain it
explain
in
it in
Bengali.
Bengali.
But
But
people
people
who
who
follow
follow
Hindi
Hindi
can jolly well
can
follow
jolly
what
well
is
follow
being
what is
said
being
in
said in
Bengali.
Bengali.
Please.
Please.
ডক্টর এবেল বা ডক্টর দেবাঞ্জলি যেটা বললেন সেটা হচ্ছে ফাইব্রোমাইলজিয়া এমন একটা ডিজিজ যেটা সারা শরীরে মানে কোথাও একটা শুরু হয় এবং সেই ব্যথাটা সারা শরীরে ছড়িয়ে পড়ে এবং আমরা এটাও বুঝতে পারি না কখনো কখনো যে কেন এই ব্যথাটা হচ্ছে এবং সেটা একটা ভিশিয়াস সাইকেলের মতো চলতে থাকে। হ্যাঁ, অনেক সময় দেখা যায় অন্য কোনো কারণে, যেমন ডক্টর দেবাঞ্জলি বললেন যে ট্রাইজেমিনাল নিউরালজিয়ার পেশেন্ট, কিংবা ধরুন কোনো পোস্ট ট্রমাটিক স্ট্রেস ডিসঅর্ডার, মানে কোনো একটা বড় কিছু ট্রমা তার জীবনে ঘটেছে এবং তারপরে ডিপ্রেশন হোক, অ্যাংজাইটি হোক বা আদার কোনো সাইকোলজিক্যাল ইস্যুস থেকে হোক, সেইখান থেকে প্রেসিপিটেট করছে এবং সেখানে প্রচুর হিউমারাল চেঞ্জেস আমাদের ব্রেনে ঘটে, যেটা ডোপামিন বা সেরোটোনিন লেভেলগুলো বেড়ে যায় বা কমে যায়। এই সমস্ত কারণে কিন্তু এই ফাইব্রোমায়ালজিয়া প্রেসিপিটেট করে এবং তার ট্রিটমেন্টের দিকে আমরা আস্তে আস্তে আসবো। এবার আমাদের বলা হয় 4 কোয়াড্রেন্ট পেন, মানে সারা শরীরটাকে যদি আমরা 4 ভাগে ভাগ করি তাহলে এই 4 কোয়াড্রেন্টের বিভিন্ন কোয়াড্রেন্টে কিন্তু পেনটা দেখা যাচ্ছে। মেনলি হচ্ছে হয়তো হেডেক, সেখান থেকে আস্তে আস্তে থাকতে থাকতে সেই পেশেন্টটা মানে সারা শরীরে একটা ব্যথা নিয়ে প্রেজেন্ট করছে। সিমিলারলি কিন্তু আমরা এরকম অনেক পেশেন্ট দেখি যারা লো ব্যাক পেন নিয়ে প্রেজেন্ট করেছেন, পিআইভিডি মানে প্রোল্যাপসড ডিস্ক নিয়ে প্রেজেন্ট করেছেন, কিংবা একমাত্র শুধুমাত্র হয়তো স্যাক্রোইলিয়াক জয়েন্ট পেন, তারাও কিন্তু আনট্রিটেড যদি থেকে যান তারা কিন্তু এই ফাইব্রোমায়ালজিয়ার দিকে আস্তে আস্তে চলে যেতে পারেন। I think Dr. Vaibhav needs to
Dr. Abel
proceed
Lawrence
further.
add করেছেন
হ্যাঁ,
হ্যাঁ
ডক্টর
ডক্টর
এবল
ইবুল
লরেন্স
লরেন্স
অ্যাড
অ্যাড
করেছেন
করেছেন
যে
যে
অন্য
অন্য যে
কমরবিডিটিস
আর
রেস্টলেক্স
রেস্টলেক্স
ফ্ল্যাগ
ফ্ল্যাগ
সিন্ড্রোম
সিন্ড্রোম
যেখানে
যেখানে
পেশেন্ট
পেশেন্ট
সারা রাত
সারা রাত
ছটফট
ছটফট
পা
পা
নিয়ে
নিয়ে
করতে
করতে
পারে।
পারে
ক্রনিক
ক্রনিক
ফ্যাটিগ সিন্ড্রোম
ফ্যাটিক সিন্ড্রোম
যেখানে
যেখানে
পেশেন্ট
পেশেন্ট
অল্প
অল্প
কিছু
কিছু
কাজ
কাজ
করলেই
করলেই
মনে
মনে
হয়
হয়
একদম
একদম
ক্লান্ত
ক্লান্ত
হয়ে
হয়ে
পড়ে
পড়ে
গেছে।
গেছে
ব্লাড প্রেশার,
metabolic syndrome,
obstructive
obstructive
sleep
sleep
apnea.
apnea.
Dr.
Dr.
Lawrence
Lawrence had
said that
said
earlier
that
also.
earlier also.
Dr. Vaibhav,
Dr. Vaibhav,
I would
I would
request
request
you
you
to
to
invite
invite the next
the next
faculty that we have. Please unmute yourself, Vaibhav.
Sorry. Okay, as we continue our discussion on fibromyalgia, I would like to invite another esteemed expert to share their insight, Dr. Bhaskar Mukherjee, who is a consultant psychiatrist and molecular neuroscience specialist and has a profound expertise in psychiatry and a deep understanding of psychological aspects of chronic pain conditions. And he brings a unique and invaluable perspective to our panel. So please welcome Dr. Bhaskar Mukherjee. So,
Yes. Let me correct few things first. There is no psychological perspective because psychology is a non-medical subject, and so there cannot be any psychological perspective. Number two, mind doesn't exist, so no symptom can be psychological. Number three, I have been listening to the speakers speak, and I understand that the basic problem people are facing is people are thinking that brain is just a background thing and all other systems are there, they are doing all the thing and brain is just a passive thing. Sorry, that is wrong. For example, brain is the main organ, brain and CNS, which determines chronic pain. Now there is another problem, that is you are referring fibromyalgia as a disease. No, fibromyalgia is not a disease. It's just a symptom with some criteria. It can never be a disease because there is no specific pathophysiology of fibromyalgia itself. The specific pathophysiology is pain, increased pain due to a lot of causes. Now, that is associated with central nervous system. The descending pain pathway, the spinal astrocytes, which lines the spinal central CSF channel, and along with the spinal microglia, along with all the brain's various descending inputs, they determine whether a person would have increased pain sensitivity or not. And that has a strong genetic basis. Next is no. Depression is not the cause of chronic, not the result of chronic any suffering. Depression, the name means nothing. Low mood is normal and low mood is a normative trait. Low mood can happen with anything and anyone. Low mood doesn't make itself a disease. So the disease which is in the background are again not a single one. There are almost 4 to 5 crore disease in central nervous system, and those central nervous system diseases make the brain unable to act when the increased functional demand is placed on brain. That leads to a functional restriction, which leads to a lot of changes in brain's cell and other things, and ultimately all of them lead to reduced ability to handle any physiological demand from environment, be it external environment or internal environment, as well as executive dysfunction, as well as mood dysregulation, as well as increased pain sensitivity. And these 4 to 5 crore or more diseases, they are the silent non-communicable diseases of brain. And if we want to place a cause for fibromyalgia, then I would say they are the causes. So again, depression doesn't exist. What exists is something else. I hope I have cleared the basic misconception that we so far speakers have talked about. Now, let me talk about what is fibromyalgia. Fibromyalgia is a condition where their brain actually has an increased pain sensitivity. Now, any sensation, be it pain, be it pleasure, be it anything, has multiple components. One component is peripheral, where the actual sensory process is happening. Then there is a second component, that is spinal, where the relay and amplification of the sensation or suppression of the sensation happens. Then the third one is thalamus, where all the sensory inputs are relayed, and at thalamus there is another sort of gating, the thalamic microcircuits, which are modulated by amygdala input as well as basal ganglia input, and that filters whether the sensation would be amplified or not. Lastly, these sensations would go into various cortical relay area, and there they would be collated, they would be understood, and they would be matched with brain's previous experience, brain's emotional values and other things, and ultimately we would feel the sensation. In fibromyalgia, one or multiple of these nodes, they have less suppressive capability and more sensitizing capacity. So that can be at the level of spinal cord, that can be at the level of thalamus, or that can be at the level of central executive network, which would cause the pain sensation to have an emotional component and other. So standing there, it is no wonder that pain should be treated as, specifically these chronic pain sensations, they should be treated as first and primary CNS dysfunction. It matters not whether it is a peripheral nervous system thing which has triggered this thing. Ultimately, it is a central nervous system dysfunction. This dysfunction is of multiple types. As a molecular neuroscience person, I would say the first cause and the most important cause is genetics. Multiple genetic regulation of microglia, astrocyte, neuroimmune system, as well as the neural communication system that is impaired there. Then there is other factors which are again immune system factor. But when I say genetics, it would invariably involve immune system too, then endocrine system and other. And I would say regarding the treatment part, counseling and stress sensitization is not really the approach. The first and foremost approach should be giving adequate medical treatment to increase brain capacity to understand the functional load and to withstand the functional load. Means we need to give the brain medications which would increase the brain's capacity to work. The so-called antidepressants, which are not antidepressants because they don't improve mood, rather they increase brain's functional capacity. That's why work in fibromyalgia. Then there are medications which work in neuronal transmission and which work in neuronal excitability. For example, so-called anti-epileptic, so-called antipsychotic. They, in suitable dose, would reduce the neuronal transmission as well as neuronal excitation. In that way, they would reduce the various sensation, including pain sensation. Now, all these CNS acting molecules, they also have their immunomodulatory effect and other genetic effect. And ultimately, this would lead to change in the overall pain perception. But does that mean these patients have to take antidepressants, so-called, as well as other psychiatric medication for some time, and they can be managed with other things? No, it is not possible. As I say, it is a primary CNS genetic vulnerability that has created this hyper perception of pain. So such CNS genetic vulnerability would remain throughout their life, and they would need lifelong medical treatment from psychiatric medication. It matters not who prescribe it, because ultimately no medication is psychiatric or cardiovascular or other thing. Medication is a medication. What people need to know that how to use this medication, and they have to use this medication lifelong. So I hope the misconceptions that are going around could be somehow changed. I don't know whether I am going to be able to change the misconception, but you have to understand that brain is not the comorbidly affected organ, it is the main affected organ, followed by other systems, immune system, as well as coagulation system, as well as other peripheral organ system, as well as peripheral organ system. But CNS is the primary one. And if I just want to add one more thing, that there is a group of neuromodulation that are directed towards spinal cord. They also have a role in managing these chronic pain sensations. And with it, I would like to conclude my remarks.
Dr. Devolina,
would you
would you
please
please
sum up
sum up
what Dr.
what
Bhaskar
Dr.
had to
Bhaskar
say?
had to say?
Can we ask questions?
Yeah.
Obviously, I would be
Yeah,
happy
you
to
can,
answer
Yeah,
but
you
we
any
can,
will
but
question.
just
we will
wait
just wait
before we
before
have the
we
rounds
have
of
the rounds
the
of the
speakers
speakers
done. I
done.
know you have
I know
raised
you
your
have
hand,
raised your
and
hand,
I'll
and
definitely
I'll
allow
Dr.
you.
definitely allow
Sharma, if
you.
there is some problem, I think if it is possible for you, I have some problem in this network now.
So I think we should continue with next speaker. Then we'll
Yeah,
take
I think.
questions.
Yeah, I think.
Uh,
Uh,
Before we move
Before
to
we
the next
move to the
speaker,
next speaker,
I would
I would
Dr. Abel
Dr.
has
Abel
been
has been
putting some
putting
comments.
some comments.
So
So
you will just
you will
add the
just add
or
the or
because I think you
because I
have
think
a
you have a
different sort of
different sort of
opinion
opinion
because it is
because
a
it
white
is a
elephant
white
in the
elephant
room,
in the room,
and
and
everybody
everybody
has every
has every
speciality, and they are
speciality,
right,
and they are right,
have their own
have their own
opinion, and
opinion,
they
and
are very much
they are
right
very
in
much
their
right in
opinion. I
their
do not
opinion. I
have
do
any
not have any
conflict with
conflict
that.
with that.
But
But
Dr. Abel,
Dr. Abel,
before we proceed
before
to the
we
next
proceed to
speaker,
the
I
next
would
speaker, I
request
would
you to
request you
what you
to
wanted
what
to
you
say
wanted to
about.
say about.
Uh,
Uh,
yeah.
yeah,
I hope I would get a chance to give my opinion then.
Yes,
No,
sir.
I was
yes,
not
sir.
Definitely, sir.
Definitely,
differing
sir.
from.
It is a
Sir. It
definite.
is a
I was not
definite.
contradicting. I was supporting. This is fibromyalgia is not one disease. It is many diseases with a common manifestation, and that is what I was just There's no
Yeah.
difference of
Yeah.
opinion here.
Oh, okay.
Oh,
Sorry.
okay.
It
Sorry,
was my
it was my
misinterpretation that
misinterpretation
you
that you
wanted to say
wanted to
something
say
I
different.
was
something different.
clarifying, like comorbidities. I did not mention many of the important
Yeah, that I
comorbidities.
Yeah,
So
that
I
I
just
that
listed
that
them.
I
that I
enumerated
enumerated
and then the
and then the
presentations also.
presentations also.
So
So
yeah,
Sjogren is
yeah,
another very important thing you should always look for in fibromyalgia,
I think
because
for that
I
Sjogren
think
matter,
for
is
that
missed
matter,
even by rheumatologists. Even rheumatologists miss Sjogren syndrome. So that is something we have to be very careful.
and I think
and I think
fibromyalgia and
fibromyalgia
as
and
such
as
can be
such can be
associated or should
associated or should
be always
be
thought
always thought
for any
for
chronic
any chronic
disease.
disease.
Mane,
Mane,
definitely
What
definitive or
I would go so far as to say presence of no disease excludes Sjogren syndrome, and presence of Sjogren's syndrome does. Presence of no disease excludes fibromyalgia. Presence of fibromyalgia doesn't exclude any other disease. It is not an
okay,
exclusion.
sir.
okay,
It's a
sir.
Okay.
principle.
Okay,
Yeah.
yeah,
Vaibhav.
Vaibhav.
Okay. So, our next speaker, it is my great honor to introduce Dr. Saikat Ghosh. He's a distinguished consultant pain physician and esteemed director of Asta Pain and Sleep Clinic. Dr. Ghosh is leading expert in the field of chronic pain management. Dr. Ghosh's impressive contribution to rheumatology are well recognized, having authored several chapters in renowned rheumatology textbooks. His work extends to his role as a research scientist at Indian Council of Medical Research. We are privileged to have Dr. Ghosh with us today to share his extensive knowledge and insight on non-pharmacological management of fibromyalgia. Mr. Ghosh, Dr. Ghosh, over to you.
Dr. Ghosh,
Dr.
it will
Ghosh,
be
it
nice
will
if
be
we
nice
can
if
see
you
your
can see
face.
your
Yeah,
face.
if we can see
Yeah,
your
if we can
face.
see your face.
Hello. Actually, I'm in a car. It's a dark one, so I can't open my video. Hello. Am I
Yeah,
audible?
please go
Yeah,
ahead.
plece go
Yeah,
ahead.
please go
Yeah,
ahead.
please
You're
go ahead.
very
Yes,
much
You're
you
audible.
very
are
much.
audible. Please continue.
Okay. So the major part of the non-pharmacological management of the fibromyalgia is primarily the lifestyle of the patient. here I will I just want to focus on the three things. Number one, the most important thing is the patient's daily activities, and this includes a good healthy lifestyle with a proper diet, with a good sleep hygiene. A sleep hygiene is very much important in case of the fibromyalgia, and maintaining a good sleep hygiene can decrease all the symptoms of the fibromyalgia and the associated all the symptoms to a great extent. Number two, the exercise. People who are doing a regular exercise are much less prone to the severe forms of the fibromyalgia. Number three, then there are the multiple dietary interventions have been found to be beneficial in fibromyalgia. For that, in one randomized control trial and another 2 to 3 non-randomized control trial, it was found that the people who takes more amount of the tryptophan and the magnesium-rich foods, like the walnuts, they have less symptoms and they are much less prone to have the severe forms of the fibromyalgic symptoms. Moreover, the fibromyalgia is also associated with the multiple GI symptoms like irritable bowel syndrome or the GERD, and these are also regulated if the people maintain a good dietary as well as the sleep habit. Number four, another non-pharmacological management is the use of the dry needling or the acupuncture. So in case of the multiple refractory patients, it was shown that doing a proper acupuncture by an acupuncturist can lead to decrease the symptoms of the fibromyalgia and even can induce remission in the multiple drug-resistant cases. So, but here the research papers are not RCTs, so we need more research on that, but it's an option, I want to say rather. Finally, I want to say, stress on another thing, that the people who are suffering from the fibromyalgia, they should also, as my previous speaker already told, that they should always look for the other diseases, like the Sjogren's. So the people, we often miss it, that the dry eyes, the people are saying about that they have the dry mouth. People often present with the Raynaud's syndrome, that we also just don't look over, we should not look over for that. And if all these aspects are taken care of, so these can lead to a better life for our fibromyalgic patients. Thank you. Hello?
Yeah.
Dr. Shaigar,
Since you're driving, I would have preferred, I would have asked you to explain the same thing in Bengali, but I would request Dr. Devalina, if possible, to sum up on the.
আমি বলে দিচ্ছি সেটা হচ্ছে ডক্টর সৈকত যেটা বললেন মেনলি 3-4টে জিনিস আমাদের নন মেডিকেল ম্যানেজমেন্ট কিন্তু ভেরি ইম্পর্টেন্ট। সেটা হচ্ছে একটা হচ্ছে ঘুম, স্লিপ, একটা হচ্ছে ডায়েট আমরা যেগুলো রেগুলার খাই, এক্সারসাইজেস, আর আদার কোনো ডিজিজ আছে কিনা সেটা খুব সুন্দর করে দেখতে হবে, যে খতিয়ে দেখতে হবে সেই ডিজিজগুলো আছে কিনা। স্লিপ হচ্ছে সমস্ত কিছু হিলার বলা হয়, প্রপার 7 to 8 আওয়ার্স সাউন্ড স্লিপ অনেক ফাইব্রোমায়ালজিক যে কম্পোনেন্টসগুলো বা তার যে সিমটমসগুলো কিন্তু অনেক কম করে দেয়। ডায়েটের মধ্যে ডক্টর সৈকত যেটা বললেন, মেনলি ট্রিপ্টোফ্যান রিচ ডায়েট, ওয়ালনাট, ম্যাগনেসিয়াম রিচ ডায়েট, এগুলো কিন্তু খুবই উপকারী ফাইব্রোমায়ালজিয়া পেশেন্টের জন্য। এবং ফাইব্রোমায়ালজিয়াতে এরকম অনেক সময় দেখা যায় আন্ডারলাইন জিআই সিমটমস থাকে, কারোর ইরিটেবল বাওয়েল ডিজিজ থাকে, জিইআরডি থাকে, এই সমস্ত পেশেন্টের জন্য কিন্তু ডায়েটটা খুব ইম্পর্টেন্ট। তো এটা 2 নম্বর হচ্ছে যে এই পেশেন্টেরই আদার আন্ডারলাইন কিছু ডিজিজ, যেমন ডক্টর এবেল বারবারই বলছেন রিউমাটোলজিক্যাল ডিজিজ, জোগ্রেন সিনড্রোম, যে মুখ শুকনো হয়ে যাচ্ছে বা চোখটা খুব শুকিয়ে যাচ্ছে, বা রেনল্ডস সিনড্রোম, যেটাকে বলা হয় মানে ভেসেল যেগুলো রয়েছে সেগুলোই কনস্ট্রিকশনের জন্য পেরিফেরি গুলো ঠান্ডা হয়ে যাচ্ছে, এইগুলো কিন্তু অনেক সময় ফাইব্রোমায়ালজিয়ার সাথে অ্যাসোসিয়েটেড থাকে। এছাড়াও কিছু পদ্ধতি যেমন ড্রাই নিডলিং এর কথা ডক্টর সৈকত বললেন, বা আকুপাংচার, কিন্তু অবশ্যই ডেফিনেটলি কোনো স্পেশালিস্ট বা এক্সপার্ট কাউকে দিয়ে মানে যেখানে দরকার সেখানে এগুলো অ্যাপ্লাই করতে হয়। তো এক্ষেত্রেও বেশ কিছু ক্ষেত্রে দেখা গেছে ড্রাই নিডলিং এবং আকুপাংচারও কিছু ক্ষেত্রে হেল্পফুল। ওভার ডক্টর সঞ্জয়।
Vaibhav, please continue.
Doctor.
Okay. So I think we should take questions from the audience now.
Dr. Devashish, you wanted to ask something?
হ্যাঁ সৈকত, ডক্টর সৈকত, তোমাকে আমার প্রশ্ন, যে তুমি বলছো ড্রাই নিডলিং আর আকুপাংচার তফাৎ আছে কোনো? প্রথম প্রশ্ন, ড্রাই নিডলিং আর আকুপাংচার কি কোনো তফাৎ আছে? দুটো কি আলাদা জিনিস? দ্বিতীয় প্রশ্ন, সেকেন্ড কোয়েশ্চেন, যে আকুপাংচার মানে which points should we use to reduce the fibromyalgia, if I am audible? Hello?
Yeah, you are audible.
Yeah, you are audible. Shaukat, are you able to?
Hello.
হ্যাঁ সৈকত বল। হ্যালো,
আমরা এই কোয়েশ্চেন দুটো রাখছি। ডক্টর সৈকত মনে হয় শুনতে পাচ্ছেন না। ঠিক আছে, আমরা
Hello, am I audible? Am I audible right now?
Yes, you are. Yes, you are audible.
Okay. So thanks for the question, Dr. Jatwa. Number one, your question is whether the dry needling and the acupuncture are the same thing or the different thing. So the answer is the dry needling and the acupuncture are not the same things. Dry needling and the acupuncture are the different things. So what is dry needling? In case of the dry needling, we found the trigger points or the tender points, and we do the dry needling. Then we do insert the stainless steel generally needle in that point, which helps to relieve the symptom of the patients. But in case of the acupuncture, that doesn't only occur. So in case of the acupuncture, what we do, we have some acupuncture specific points, and that helps to just decrease the symptom of the patients, and we do the needling there in those particular specific points, and these are not only related to that trigger point or the tender point, and there are multiple distant points as well, and these are also helpful.
But in acupuncture, any point where pain is there, if we give a needle, the acupuncture needle, that is the Ashi point, it becomes the Ashi point.
Yes,
so
the
whatever
Ashi
you
point
are saying,
needling
tender
is
point,
found.
that is the Ashi point. Anywhere
Yes,
there is pain, you put the needle, that is called Ashi point, it becomes automatically an Ashi point. So that is there in acupuncture.
No.
It is just a paper
no.
from acupuncture, nothing else.
No. Just a second, Dr. Jatwa. What I just want to mention that the Ashi point acupuncture is found to be inferior than the traditional acupuncture in case of the fibromyalgia. So Ashi point acupuncture is there. Obviously, what you have told.
I am not saying.
Sorry to intervene, but I think we can
discuss the details of acupuncture and
Okay. Forget. I've got another. No, okay, the
But I
point.
think
Any other
fibromyalgia, as
point?
far as the lay persons are concerned, this is a program where we are discussing fibromyalgia as understood by the lay persons,
Okay,
or
sir. I have got
what they
question
need
for
to understand.
Dr. Bhaskar also. Okay, I've got question for Dr. Bhaskar also. Let me ask my question. Or if you want to say continuously, oh, you can go continuous. Or let me ask the question, Dr. Bhaskar. Now, Dr. Bhaskar, you said that fibromyalgia is not a disease because it does not have pathophysiology. So,
Yes.
but you yourself has at least cited 5 pathophysiologies for fibromyalgia. So then it does become
Yes.
a disease, does not it?
No, I have cited not only 5. Actually, I have cited multiple etiologies for chronic pain sensitization. But chronic pain sensitization has thousands of causes, which results in a common symptom of chronic pain amplification or sensitization, whatever we call. So standing there, fever also has thousands of pathologies. Thousands, or I would not say even thousand, millions of pathologies resulting in elevation of body temperature. Does that make fever a disease or a symptom?
So in your opinion, what shall we call fibromyalgia? A disease, a case, or a symptom? Just a symptom.
A, a symptom of multiple dysfunction in CNS sensation relay system. That would
Okay.
be the most appropriate term standing in 2024. Maybe in 2026 or 27 we would say something more.
Thank you. Thank you.
Dr. Gautam,
Dr. Gautam,
Dr. Deepak
Dr.
Kumar
Deepak
Gautam has a
Kumar Gautam has
question.
a question.
Dr. Gautam,
Dr. Gautam,
I think.
I think,
Am I audible now?
Yeah, you are very
yeah,
much
you are
audible,
very
sir.
much audible, sir.
Sorry, I forgot to unmute. So my question is that it is found in the CSF of fibromyalgia patients that the opioid peptides are usually high. Okay, the amount of opioid peptides is usually high in fibromyalgia patients. I just wanted to know through the experts, that is it a universal phenomena and can it be standardized to aid in the diagnosis making also? Is my question clear?
Yes, the question is clear. The problem is it is not a universal finding. So
Okay.
we cannot say it is a marker. But yes, in fibromyalgia, or rather in central pain, chronic pain syndromes, there is generally high level of spinal opioids. It cannot be generalized, but it is generally, there are people in whom it is normal, but otherwise opioid level, endogenous opioid levels are pretty high, because it
Okay.
is not due to not opioid pathway deficiency.
Okay. Okay. Thank you, sir. Thank you. I just wanted to know whether it can be of any help in the diagnosis. Thank you.
Can I add something about this substance P, increased substance P levels is what I think you are talking about. It is there, but the problem is that substance P antagonists fail
Have
to
not
do
yet.
any benefit, which shows that increased substance P is not the problem.
Okay.
And this is also
Exactly.
cited as the reason for, I have some hypothesis why this is so, because substance P signaling is important in negative regulation of stress pathways. That is, when you are in stress and all these things, down regulation, that is the nerves that go to hypothalamus and then it subsequently inhibit stress, actually substance P mediated. So if you block substance P, it's not only the pain, there is the negative mechanisms in down regulate pain also get blocked. So
Okay.
that's why you can't think of it. And again, this oxytocin pathway inhibits the substance P, that is urocinin receptor that layer of the spinal cord, that is where this oxytocin also acts. So there is a complex interplay between multiple pathways.
Okay.
And there is a lot of something which does one way, does the other way also. So net effect is cancelled by many of these pathways. Even the descending nociceptive inhibition can both increase and decrease pain. And in people with chronic pain, it is actually flipped.
Thank you, sir. That answers my question. Actually, I had the doubt like that only. So thank you so much, sir.
Dr. Vaibhav.
Dr. Vaibhav,
can you?
Okay. I would like to put on some general, some questions which laymen will have about fibromyalgia. So this question is for Dr. Abel. Are there any support group or organizations for people with fibromyalgia in India?
I am not associated with it. We need to create a support group for many reasons, not only for this thing, but for it will help improve, it will make it easier to conduct studies and trials and with patient participation. And I think another important area of work we should be doing is what is the long-term outcome of fibromyalgia. Many people think that fibromyalgia is a benign disease. It is not so. There are enough studies which show that people with chronic pain are more likely to die, increased mortality. Second, I want everybody to guess what is the odds ratio for development. You know that dementia risk is increased in diabetes, and diabetes is a common disease. Fibromyalgia is a common disease, and diabetes has increased risk of developing dementia, and it is widely discussed. How is the risk of dementia in fibromyalgia in relation to diabetes? Just try to think. No need to answer. In fact, the odds ratio for dementia and diabetes is 1.5. That is 50% increased risk of developing dementia. Whereas in fibromyalgia, it is 2.5. That is 150% increased risk of development of dementia. So why this causes, we don't know. So fibromyalgia should not be considered as benign without consequences. And, again, people... in fact, the disease with the highest association, a lot of people with osteoarthritis have fibromyalgia. Is it OA causing? Probably it is fibromyalgia is increasing risk of osteoarthritis. So fibromyalgia may have consequences. Nothing has been studied. There are no longitudinal outcome studies of fibromyalgia.
No, but is there any support group in India for fibromyalgia?
I do not have that answer to that question.
No. Any of the experts do you know of any support group or any group of that the common people can go to? They can discuss like
there
whole group. Any support group in India? Any of the panelists? No idea.
Okay, that answers our question. Next question is
just a moment. Vaibhav, if somebody else has an idea, we have a lot of national faculties and teachers out here with us, and some of the prominent pain physicians also. So if they are aware of any faculty, a support group, or if they are running a support group themselves for their patients, we would ask them to please speak up.
In Jaipur, there is actually Indian Fibromyalgia Association which runs a support group. That I know. But I would be saying to people that contact them. They can guide you to the support group.
Okay, sir. So,
আমি একটু বাংলায় বলে দিতে চাইছি, ডক্টর ভাস্কর একটা খুব ইম্পর্টেন্ট তথ্য দিলেন। আমি একটু কলকাতা বা ওয়েস্ট বেঙ্গলের সবার জন্য একটু বলতে চাইছি। ডক্টর জাতীয় খুব একটা ইম্পর্টেন্ট কোয়েশ্চেন করেছিলেন যে আমাদের ইন্ডিয়াতে কোনো সাপোর্ট গ্রুপ আছে কিনা, যে যারা ফাইব্রোমায়ালজিয়া সাপোর্ট গ্রুপ। তো ডক্টর ভাস্কর এক্ষুনি জানালেন যে জয়পুরে ইন্ডিয়ান ফাইব্রোমায়ালজিয়া অ্যাসোসিয়েশন যেটা রয়েছে তাদের একটা সাপোর্ট গ্রুপ আছে। তো যদি কেউ চান সেখানে যোগাযোগ করলে তারা কোনো লোকালিটি সাপোর্ট গ্রুপ সম্বন্ধে কিছু আইডিয়া বা খবর দিতে পারেন।
And there is a group in Facebook too. Facebook support Fibromyalgia Support Group India.
Okay, that's great.
ওকে,
So my next question is for Dr. Bhaskar Mukherjee, sir. How can family and friends support someone with fibromyalgia?
How can family and friend support someone with fever? They can take them to doctor. They can give some reassurance. That's it. There is no other specific family guidance required for any of the brain diseases. Like all other diseases, the basic support along with direction towards proper doctors for managing the brain condition. Encouraging the patient to live a healthy lifestyle. That's it.
So in short, you are saying, Dr. Bhaskar, that they can either go to a psychiatrist or a pain physician and they will be guided properly.
They can go to a multidisciplinary team. Only psychiatrist, only pain physician should not handle this type of thing. There a team should have one brain physician, if that is psychiatrist or if that is neurologist, well enough, one pain physician, one person experienced in immunology and various rheumatic diseases, and the last person should be someone having enough knowledge to give various invasive pain modulation procedure. If the pain physician can do it, well enough, or we need someone with interventional knowledge. This type 4 people.
I would like to add, fibromyalgia should be managed by teams. You need multiple people to be involved. For example, even but each specialist should have interest in fibromyalgia. The biggest challenge is that many doctors, even different specialties, don't have interest in fibromyalgia. People who don't have interest in fibromyalgia should not manage fibromyalgia. So rheumatologists will be required to look for things like Sjogren syndrome and many other conditions. And secondly, sleep cessation is also important because one of the common pathology is sleep. And sleep studies can give insight into comorbidities. You might be able to diagnose various sleep disorders. So disturbed sleep can cause fibro. If you can diagnose the underlying sleep disorder and manage that, that might improve some of these things. So similarly, so it requires a multidisciplinary approach, and identifying some undiagnosed entity which is treatable is actually very, very important.
Okay, as to sum up what Dr. Jatua had asked, कि अगर कोई सपोर्ट ग्रुप है कि नहीं भारत में या भारत के बाहर में, तो एक डॉक्टर भास्कर का कहना है कि एक जयपुर में जरूर है एक ग्रुप, और उनका एक फेसबुक पेज भी है। और जहां तक कि फैमिली का सपोर्ट की बात है, डॉक्टर भास्कर मुखर्जी का ये था कि जैसे किसी के बुखार हो जाती है या कोई भी कंडीशन होती है, तो उस समय जैसे फैमिली सपोर्ट करती है, वैसे उसको फाइब्रोमाइल्जिया में भी सपोर्ट करना चाहिए। इसके अलावा जो डॉक्टर एबल और डॉक्टर भास्कर का कहना है कि एक अगर किसी डॉक्टर के पास आप जाते हो और अगर उसको फाइब्रोमाइल्जिया में इंटरेस्ट नहीं है, तो उस डॉक्टर को इसमें काम नहीं लेना चाहिए, नंबर 1। नंबर 2, क्योंकि फाइब्रोमाइल्जिया काफी कुछ बीमारियों के संग जुड़ा हो सकता है, और कई बार पेशेंट को एक से ज्यादा प्रॉब्लम्स होती हैं, जिसके बाद वो फाइब्रोमाइल्जिया की एक ब्रॉड हेडिंग के अंडर में आता है, सिम्टम वाइज, नॉट ये बीमारी नहीं, किंतु बीमारी के लक्षण की तरह है ये। और वो जो है वो उसमें मैनेज करने के लिए सिर्फ एक डॉक्टर, एक या दो रिमेटोलॉजिस्ट या साइकियाट्रिस्ट, ये एक मल्टी स्पेशलिटी मल्टी ग्रुप होना चाहिए. एंड इफ you agree with me, Dr. Abel and Dr. Bhaskar, in this particular group of multi specialities involvement, even some of the patients who have been sufferers and who have come out of it, or at least are in a better state, can also add on in a group discussions where they can share their experience, share their journey about from being severely disabled to being able to socially active. Yes, sir. Dr. Bhaskar and Dr. Abel.
Yes.
I just want to add one thing. Excuse me. I just want to one thing about the family participation. The family participation is very much important in not only cases it's treating like a fever or any problem, but to provide a good, healthy home for having a good sleep and a good lifestyle. That is also very vital. Some patients come to me that they are due to their family conditions, they are due to they are making the other peoples are not cooperating with them to have a good sleep. So these are very much vital. So the people in the family or the friends should not only just take the patient to the doctor who is concerned with, but also provide the patient the essential, the surroundings, the environment to have a great sleep and a good lifestyle also. So these are very vital things for the families and the friends, as per my check.
Sir, I also have a question to Abel
Yeah,
sir
please,
and
just a moment, just a moment. I just wanted to Dr. Abel and Dr. Bhaskar to add to what I thought was a good approach to involve the patients in patient's care. You know, like in a group meeting where they can talk about their experience. Does it work? Dr. Bhaskar, Dr. Abel.
Yes. Yes. The thing is, having someone who is battling the same symptoms and who has seen some good responses would actually give a person some hope. And hope is one of the strongest motivator of brain states. Brain reward system gets motivated by hope to a great extent, and that is the basis of placebo response in our various medical fields. So I won't debate this point. I would say yes, having someone would actually help. Over to Dr. Lawrence.
Patient education is very important in this because patients usually have many doubts, and especially patients' trust with the healthcare system and the doctors will be at a very lowest when they come to you with fibromyalgia, because they have had so much negative experiences, different people saying different things, and many patients gaslighting the patients, many doctors saying you don't have anything, this is psychological, etc., which is not correct. And in fact, you need to educate the family and the patients about what actually fibromyalgia is and what fibromyalgia is not. And it is also very important to avoid maladaptive practices. That is, patients' lifestyle and things should be helpful. For example, many patients have chronic fatigue syndrome. So if you stop doing teaching them to do exercise is a very, very important thing. If you don't do exercise, their sphere of activities will come down further, worsening. In fact, there is no good treatment for chronic fatigue syndrome. But at the very thing you can do is prevent it from getting worse. So teaching them about this and so patient education is cornerstone, and it decreases a whole lot of stress and this depression. I also agree with the previous speakers that fibromyalgia is not depression. That's absolutely, in fact, in epidemiological studies, there is no association with fibromyalgia and depression. And as shown in various things, it is the patients who come to the hospital, who are brought to the hospital, who have depression. And the biggest association in epidemiologic studies is with PTSD and anxiety spectrum diseases. And one anxiety spectrum disease which is not associated with fibromyalgia is OCD. I don't know why. Maybe that also may give some clue to what fibromyalgia is.
Okay, sorry.
Thank you.
Thank you.
Dr. Piali.
Dr. Piali.
Yes, sir. My question is to Doctor. It was a very nice presentation, though. It's a very nice and enthusiastic panel discussion. My question to Dr. Abel and Dr. Vaskar both, that they are saying that it is a multidisciplinary approach, the holistic approach for the fibromyalgia. Does it any have role to include the rehabilitation specialist in treating fibromyalgia, sir? Abel, sir?
See, I'm not. See, we don't have a department of rehabilitation, so I don't have much of a thing, and I might be ignorant. But suppose in somebody with rheumatoid arthritis with deformities, which actually physical problems need rehabilitation. Here, patients is education. Most patients, unless they have another comorbidity which requires rehabilitation, somebody with a pure fibromyalgia, it is education and management.
I would
Might be
say
able to have a better answer. I can't. I don't know.
I would say sorry to the rehabilitation medicine specialists, because yes, they have a role, because many a time physical movements, physical therapies actually compete at the sensation level with pain sensation. So that way, by competing for the dedicated ganglionic cell and dedicated pathways, they actually would help in some of the conditions of chronic pain, number one. Number two is the conditions which lead to chronic pain. Each of them would need some kind of rehabilitation, some kind of physical therapies, and their physical medicine experts do come. So, yes, in the multidisciplinary team, physical medicine experts should also join.
Thank you.
Thank you.
Dr. Jatua, do
Dr.
you
Jatua,
have
do
another
you have
question,
another
or
question,
shall I
or
ask
shall I
Dr.
ask
Manish
Dr.
De
Manish
to
De
put his
to
question?
put his question?
I have no question at this moment. Dr. Manish, they may come forward.
Dr. Manish De,
Dr. Manish De,
if you are
if
around,
you are
please
around,
ask
Yes.
your
please
question.
ask your question.
There are two questions actually. Is there any role of like mindfulness meditation, one, as a non-pharmacological approach, and second is there any role of like desensitization, like lignocaine infusion in case of refractory pains, like in refractory to all medications, all medication, lifestyle modifications, everything. So there are two questions open to everyone who are senior pain clinicians. Sorry.
Uh, I can comment that in case of the rehabilitation part, there is a great role of the people's having the good lifestyles along with the yoga and the meditation. That also has some roles in elevating the symptoms of the fibromyalgia. Not only the symptoms of the fibromyalgia, but also that can relieve the other symptoms associated with this, like the gastrointestinal symptoms and the patient's sleep disorders. This can also be helped. And moreover, the patient's total mental conditions and how it depends on the general well-being of having a great life with a good kind of the exercise, and the along with the some amount of meditations and the relaxing exercises, that is also helpful. That's all.
I would say lignocaine ketamine infusion. I don't have much expertise except some theoretical knowledge. So that is a question that should be answered by pain medicine physicians. Regarding mindfulness meditation, my take would be purely what is research findings so far. So far, the research findings say that to get a temporary effect of mindfulness meditation, someone has to do at least 1 to 5,000 hours of mindfulness meditation. Now, if you do that 1 day every day, 1 hour every day, you would find that would translate into almost 3 to 4 years. Now, for the effect to stay permanent, means the effect when they change from state to trait, which would persist whatever the person do throughout the day, that would take more than 10,000 hours of meditation. If we translate that into 1 hour per day, it would actually have almost 30 years to achieve this state. And this research data is actually evidence of various Tai Chi practitioners, various Tibetan meditation practitioners, and Tibetan lamas collaborating with neuroscientists in various universities, and by experimenting on these people who have been meditating throughout their life, these results have been obtained. So if one can do it, good enough, but be prepared to do it for at least more than a few years before you see any changes.
Thank you, sir, for the infusion information. Thank you.
I just want to add one thing that what had Sarah had said that that's a perfect thing, and another thing is that with the use of the lignocaine, so that was the procedure of the desensitization. I have not very much strong robust evidence, but in case of my own clinical practice, near about I used it for the procedure of the desensitization with the lignocaine in near about 30 to 35 patients of the fibromyalgia, and I found near about 80% symptom relief. In case of the 80% patients, some bit of the symptom relief, not it only works it's alone, but along with the other medications and all the therapies, it really helps. It's really helpful for them. Almost the 80% of the patients. Out of my 35 patients who have undergone the systemic desensitization with the use of the IV lignocaine, I found that it's a positive effect in near about the 30 to 31 patients. So that's my take.
So, Dr. Shoykot, you used only lignocaine or you used ketamine along with lignocaine?
I used lignocaine only in case of the 20 patients, and in case of the another 11 patients, lignocaine along with the ketamine.
So, which yielded with better result? Along with the ketamine or only?
Dr. Jatua, being a public forum, we cannot discuss the nitty-gritties of the medicines that are being used.
Okay.
For the public, it is important that yes, there are ways to deal with it, and we can have medicines that at least, if not entirely, but to a great extent, can ameliorate the symptoms. Sorry for being a bit upfront about it. Thank you.
I think we can say
I
what
think,
should not be
Doctor,
used. We can say what
I
should
think
not be used?
Doctor, I think
Yeah,
Dr.
definitely.
Ramapati Ishwanmal sir and Dr. Arghun Mukherjee, both are the expert pain physicians. They are present in this discussion. We just request them if they share their any expertise, knowledge or views regarding this.
Dr. Devolina, Dr. Archana Srinath wants to ask some questions.
Okay, okay, okay. We can go further.
Dr. Archana,
Sir, I
please
wanted
unmute
to
yourself.
know. Yeah, good afternoon, good evening. I'm Dr. Archana from Bangalore. I wanted to know what is the method of central sensitization, desensitization apart from the lignocaine ketamine infusion. Uh, are there any medications that can be given? Uh, Thank you.
Dr. Archana, as I had said, I think we cannot go in too much in specifics about the medications. But yes, I would definitely ask Dr. Abel that he wanted to say what not to use.
Yeah,
Yes, sir.
that is, in fact, you should not be using painkillers in fibromyalgia, and especially the analgesics like tramadol, opioids. They can get they may have very short-term relief, but will get worse in the longer term, medium to long term. And when I see patients, the most important thing is to take them off these drugs. And especially pain physicians use a lot of these. So avoidance of tramadols, NSAID. Of course, if the patient has arthritis, you may use NSAID. So what you do is use as few drugs as possible. Only the fibromyalgia drugs, which we are not using here.
Actually, I want to add to that. Pain physicians in chronic pain, these were discussing in chronic pain, no opioid should be used. In fact,
Yes.
no pain physician that I know of uses opioid in chronic pain. None from Calcutta, we are in the group. We never use opioid or diclofenac in chronic pain. That should be avoided as much as, not in fibromyalgia, most of the chronic pain patients. That's what I want to add.
And especially fibromyalgia.
Thank you, Dr. Jatwa.
Thank you, Dr. Jatwa and Dr. Abel, for your input. Dr. Manisha Jaiswal has a question.
Dr. Manisha.
Dr. Manisha.
Hello, can you hear me?
Yeah, please go ahead.
Yeah, please go ahead.
It's not a question actually. I just want to share an experience of a fibromyalgia patient. She is my patient for maybe the last 2.5 years. So she has been suffering for the past 30 years with chronic pain, widespread chronic pain. Her main complaint is severe headache. And the astonishing thing is that the patient takes analgesics like toffees, 7 to 8 at a single time. Like she takes 7 tablets of diclofenac or nimesulide, whatever she gets her hands on. So otherwise, she says that she cannot even get up from bed. And she had visited several doctors in these last 30 years, but she was never diagnosed properly. So when I diagnosed her as fibromyalgia, her son was happy in the sense that at least there was a diagnosis to what she was suffering from. And then I did a desensitization with IV lignocaine, and she was much better. But then again, the pain came back, and the second dose of desensitization did not help her much. So now I have sent the patient to a psychiatrist for CBT or hypnotherapy, whatever he thinks fit, because the patient is still, whenever she has pain, she takes medications in that dose. So I did get a kidney workup done because I was very scared about her kidneys, the way she was taking medications, but somehow they were spared. So I just want to add that it is really very difficult to treat these patients, but yes, counseling and talking to them and at least acknowledging that they are suffering and they are not just making up these symptoms which the family thinks, that really helps a lot. So that is just what I wanted to add.
I think Dr. Abel
I think Dr. Manisha just also say that analgesic, overuse of the analgesic itself can cause the severe headache.
Yeah, so I have asked her, but according to her, I mean, in India it's so easily available over the counter. So she says unless I take 7 to 8 tablets, it is not cured, and I have to get up and. I have asked her several times not to do that, but
yes, that's my question. Yes, I already they have discussed about the patient education. That is very much vital in this regard.
Yeah, but she's been suffering from the last 30 years, so it will take time to educate her.
Yes.
ব্যাপারটা এটা একটু বাংলায় বলে দিন কমন অডিয়েন্সের জন্য।
না সেটা তুইও বলতে পারছিস, মানে I think you can also say that. Just to say, মানে what Dr. Jatwa insisted was that যে পেশেন্টগুলো ফাইব্রোমাইলজিয়া স্পেশালিতে কলকাতা শহরে অন্তত পশ্চিমবঙ্গে আমরা যারা প্র্যাকটিস করছি, আমরা কিন্তু চট করে ক্রনিক পেনের জন্য, এক্সেপ্ট যদি ক্যান্সার যদি না হয়, আমরা ওপিওয়েড কিংবা ওপিওয়েড লাইক ওষুধগুলো চট করে আমরা ব্যবহার করি না। কেন এই আর যেটা ডক্টর এবল বললেন যে ওপিয়াইডস কিংবা এই ধরনের ব্যথা ওষুধ যদি ফাইব্রোমাইলজিয়াতে ইউজ করা হয় তো শর্ট টার্মে শুধু ক্ষতি করে না, লং টার্মেও ক্ষতি করে, আর ফাইব্রোমাইলজিয়া তাতে কোনো পেশেন্ট উপকার পায় না। ইজ দ্যাট রাইট দেবলীনা?
একদম। আরেকটাও যেটা আলোচনা হচ্ছে যে আমরা যে কলোকিয়াল ল্যাঙ্গুয়েজে ব্যথার ওষুধ বলি না, ওভার দ্য কাউন্টার যেগুলো পাওয়া যায়, তো ক্রমাগত সেই ব্যথার ওষুধগুলো যদি ইউজ করতে থাকি, সেই ওভার ইউজের জন্য কিন্তু হেডেক এবং ফাইব্রোমাইলজিয়া এগুলো কিন্তু প্রেসিপিটেট করে এবং অ্যাগ্রাভেটও করে। সুতরাং মানে এটাই আমাদের সবার বলার একটাই কথা জেনারেল পপুলেশনের জন্য, যে স্পেশালিস্ট বা ডাক্তারের কাছে পরামর্শ না নিয়ে প্লিজ আপনারা কেউ ব্যথার ওষুধ খাবেন না। ওপিআইড তো ডেফিনেটলি অ্যাভয়েড করা খুব জরুরি।
Dr. Weber, the next question.
Yes.
Dr. Weber, you are there?
I'm here.
I'm here. Okay, my next question for the panelist is, how can employers accommodate employees with fibromyalgia? I mean, there should be, there is a lack of public awareness and advocacy to improve the lives of those with fibromyalgia. So, is there any way?
I'm not, see, I don't know how to do that. See, increased awareness is important. But my advice for all chronic patients is that as far as possible, you should have the purpose of treating chronic disease patients is to maintain their normal life, normal social life, work life, personal life. In fact, they have to fight. I mean, you have to work unless there is something else. So, patients should not be, if you start taking leave for fibromyalgia, it will only worsen the fibromyalgia. It will increase stress, decrease activity, you will gain weight, you may develop, or your OSA, all these things will worsen. Your chronic fatigue, that will get worsened. So maintaining physical activity, social activity, work activity, all this is very important for patients, because once you stop, it's very difficult to get back. So the best way not to get unemployed is to keep employed. So while employers have to be at the one of the biggest problems in the West about fibromyalgia is absenteeism. Avoiding absenteeism is important. So basic, and I don't know, I can't say, I think it's quite possible that a lot of this happens because patients are not diagnosed on time. If you can diagnose patients on time, counsel them, educate them, and then they can get on with their lives normally. Whereas if you have these diseases, in fact, pain is a symptom of a serious something going wrong. Paining is a warning sign of the body. When somebody has severe pain, in fact, studies have shown that patients with fibromyalgia experience much more severe pain than the worst patients with rheumatoid arthritis. So the patients with fibromyalgia are experiencing real pain. And we as doctors and family members in society, we need to accept that. Instead of saying it is not psychological. In fact, all these therapies and all these, you can attempt them, and some of them are useful in some patients. But they work less effectively in patients with fibromyalgia because the pathways that decrease pain are abnormal in these patients. So you should, in fact, placebo response doesn't exist in fibromyalgia. So because pain placebo response is through opioid pathway, and opioid pathway is inverted, so it won't work. So there is no placebo response even. So this is a very challenging thing, but most importantly, maintain function.
One more very common thing which most of the patient ask is what food to avoid, and this is common for in every disease. So doctor, which food should I avoid, or which food should I eat, or is there any nutraceutical which I should take to better my condition?
See, some of the nutritional deficiency, like magnesium deficiency, can present like fibromyalgia symptoms. In fact, there are a whole lot of diseases which there are diseases which can look like fibromyalgia, but they are not numerically very important. You don't often come with magnesium deficiency. For example, mitochondrial diseases. There are many diseases which can look like fibromyalgia, but most fibromyalgia are not any of those things. So in terms of most important thing is do not gain weight. So things which increase gain weight, high carb diets, so maintaining an adequate weight, because whatever you have, the moment you gain weight and you get metabolic syndrome, most of the drugs used to treat fibromyalgia becomes less effective. In fact, if you go back to the thing, obese fibromyalgia do not respond to the standard drugs used for treating fibromyalgia. On the other hand, if you lose weight, the sensitivity of the drugs improve. The lean fibromyalgia is easier to treat. So if you are lean, do not be, it's very important, especially for a patient with fibromyalgia, not to gain weight. So that means all these general advice for people with diabetes, hypertension, these things should be. And regarding magnesium sources, especially use of processed foods is what the cause for magnesium deficiency. If you take grains, for example, it is the it is that outer covering, what do you call it, the bran that contains the magnesium, and magnesium requirement increases with age. For example, a 10-year-old requires 100 milligram, and a 20-year-old requires 200 milligram, and a 30-year-old requires 300 milligram, and anybody over 40 requires 400 milligrams of magnesium per day. And magnesium deficiency can mimic a whole lot of things. And in fact, if you have magnesium deficiency, osteomalacia may be missed, because alkaline phosphatase is a magnesium containing enzyme. And if magnesium is deficient, the rise of alkaline phosphatase you see in vitamin D deficiency will not be seen. So again, this brings us to vitamin D. Vitamin D deficiency also has lots of pain. In fact, commonest symptom of patients with vitamin D deficiency is aches and pains. And this one of my things is always give vitamin D to patients with coming with pain. Many patients' pain will go away. Again, iron deficiency can present as widespread pain. So if the patient is, especially those with restless, if you have iron deficiency, low ferritin levels, giving iron supplementation, sometimes even IV, that is, never give iron supplement, iron IV without checking ferritin. That can reduce the severity of the thing. But that doesn't mean that giving this will cure people. Some patients may have sufficient improvement so that they can go back to normal life.
Okay.
So these are, vitamin D, iron, magnesium. These are three nutrients I think people should keep in mind.
Vaibhav,
Yes.
I think Dr. Abhijit Banerjee. Yeah, I will. Next question. Vaibhav, do you have more questions coming up?
I think Dr. Anirban Pal has joined and he is doing mindfulness for a long time on so many patients. So I want to ask him one question on behalf of the society and on behalf of this group, that how mindfulness, already Dr. Bhaskar has said something regarding that, but what is your expert opinion regarding mindfulness and the role of mindfulness in this fibromyalgia patients? Have you treated this kind of patients and what is the result?
I hope I am audible. Okay. Actually, when I started with mindfulness, the first patient, the pain patient I got was suffering from fibromyalgia. She was a lady, middle-aged lady, and basically treatment failure. So a lot of people have tried a lot of things on that lady, and she was taking high doses of different medicines, but nothing was helping her. So my experience with that patient was quite interesting, and a lot of things changed in that patient. She coped with pain better, and I think when we ended the sessions with her, she said that the pain is still there, but I am less bothered with the pain now. So I think that was a compliment she gave, and she said that I can deal with my pain better or cope with my pain better. And after that, I got a few patients who had fibromyalgia, and we tried mindfulness on those patients. And the results are really good. I think in these patients, we are already, as physicians or as patients themselves, the resources which are available to them are quite limited. It may be theoretically they are many more, but in practical sense, those which are actually helping them are not so much. So here mindfulness can be a very important tool to fight with their conditions to in their day-to-day life. So it can be just another way of dealing with their mental and social things or the type of pain they are experiencing. It can change that experience of pain as well as help them to cope with this pain. And already in the American guidelines as well as in the Canadian guidelines, mindfulness is included in the treatment guidelines and is recommended for fibromyalgia patients. So I think the more the physicians become aware of this therapy, this self-help tool, and the patients also, they get to know about this and they start trying this, this can be an additional tool in dealing with their problems beside the medicines and other therapies that are there. I think this can be something which can be life-changing for them, is mindfulness training. From my perspective, my experience, what I have seen. I have dealt with maybe 6, 7 patients with fibromyalgia. That is my experience with them. But I think the more comes into application, the more helpful it will be for the patients. Thank you.
I think we are almost on the cusp of the second hour. Uh, I would request, I think, Dr. Abhijit Banerjee,
Yes,
President, has raised hand if he wants to
I'm
speak further.
audible.
Very much, sir.
Okay.
Yes. Sir.
So after this end of this, towards the end of this session, I summarize something that this fibromyalgia is often, it is not a disease, it is a symptom. It is often diagnosed, is not diagnosed as a real entity by the patient's relatives and also the neighbors and also the society. They are suffering, but they are not taken care of their pain. For this reason, fibromyalgia is not diagnosed properly here in our society. For this reason also, there is no social group which is working on that. So it was in the society, we don't know the actual scenery of the how much patients are suffering really with the fibromyalgia. We don't have any data. For this reason, in our country, there is no social group working on it, but it is very much needed. And this diagnosis is also very much needed with different awareness programs like this. So in the fibromyalgia, mainly the medicine, social help and social groups should come, and some nutritional help, some exercise, some rehabilitations, and you should recognize the patient's pain. It is a real pain. It is his or she is not malingering. That is the main thing. We should respect the patient's symptoms. And at the end of this thing, I can tell that so much, there's so many speakers have told very elaborately of all these things. It is covered very much by the general, and that can be understood by the general public also, and that is a very good thing. And I thanks to all the speakers and all the attendees who are attending to this awareness program and our ISSP Foundation Day.
That is a remarkable day for our society. So every voice is matter in raising this awareness, and this will inspire the general public for their treatment, and they should grow. They should go to the proper doctor, and the neighbors of and the relatives of the fibromyalgia patient should sympathize with the please.
Thank you so very much,
Thank you so very much,
President sir.
President sir.
Before we do a
Before
final
we do a
call,
final call, I would request anybody and
who is
everybody
around
who is
to,
around
if they
to,
have
if
a
they have
comment
a
or
comment
anything to
or
make.
anything to make.
I would now
I
request
would
Dr.
now request Dr.
Devolina to
Devolina
please
to
sum
please
up in
sum up
Bengali
in
what has
Bengali
been
what has been
discussed in
discussed
a very
in a
short
very
clip
shortly
before I move
before
on
I
to
move
my
on to my
co-moderator.
co-moderator.
আজকে একটা ইনিশিয়েটিভ ছিল আমাদের সোসাইটির কাছে পৌঁছানো রিগার্ডিং দিস ফাইব্রোমায়ালজিয়া। চারজন প্যানেলিস্ট, ভেরি এক্সপার্ট প্যানেলিস্টদের থেকে আমরা অনেক কিছু শিখলাম, ফাইব্রোমায়ালজিয়া নিয়ে জানলাম, এবং এটাও জানলাম যে ফাইব্রোমায়ালজিয়া শুধু মানে অ্যাসোসিয়েটেড উইথ পেন নয়, এছাড়া আন্ডারলাইন বহু কিছু ডিজিজ আছে যেগুলোকে রুল আউট করা, তার ট্রিটমেন্ট করা, তাকে প্রপারলি অ্যাড্রেস করা, সেগুলো খুব ইম্পর্টেন্ট। সাইকোলজিক্যাল পার্ট, মাইন্ডফুলনেস, মেডিটেশন, এক্সারসাইজেস, এগুলোও খুব ইম্পর্টেন্ট পার্ট, যেগুলো প্রত্যেকটা পার্ট শুড বি টেকেন কেয়ার অফ। খাবার দাবার যেগুলো আমরা খাই সেগুলো খুবই ইম্পর্টেন্ট, এবং সেগুলো এক্সপার্টসরা বলেছেন যে ম্যাগনেসিয়াম রিচ ফুড কিংবা ভিটামিন D3, ভিটামিন D, এগুলো খুব ইম্পর্টেন্ট পার্ট, সেগুলোকে মেনটেন করতে হবে। ফুড, জাঙ্ক ফুড অ্যাভয়েড করা দরকার। বডি ওয়েট হ্যাবিটাস, বডি ডায়াবেটিস, হাইপারটেনশন এবং আদার কোমরবিডিটিস থেকেও কিন্তু আমাদের দূরে থাকা, এবং সেগুলোকে প্রিভেনশন ইজ বেটার দ্যান কিওর, ডেফিনেটলি প্রিভেন্ট করা উচিত। And if you have the disease, then definitely you go for the treatment. Better it should be earlier. সো এটা ছিল আমাদের ফাইব্রোমায়ালজিয়া ইনিশিয়েটিভ। আশা করি আমরা সবার কাছে পৌঁছতে পেরেছি, এবং সবার হেল্প ছাড়া আমরা এতদিন ধরে সবাইকে সার্কুলেট করছি, এবং প্রচুর মানুষ অল ওভার ইন্ডিয়া জয়েন করেছেন। অনেক সিনিয়র পার্সনসরাও এসছেন এবং কমন পিপল ছিলেন, তার জন্য সবাইকে থ্যাংক ইউ। এই বলে I think we should conclude our session with the
I think Dr.
permission
Archana,
of our President and Vice President.
Sir, just a
Sir,
moment,
just a
ma'am.
moment, ma'am.
Dr. Archana,
You wanted to say something?
Yes, sir. I wanted to know if this video or this session is recorded and can we access it later?
Ma'am,
Ma'am, it is very much available on the YouTube link, that link that we had shared, and if you look for the WBSSP page on the YouTube, it is being telecast live right now.
So
It is available for posterity.
Thank you so much. Thanks a lot. Thank you for the wonderful
Thanks
session.
for your participation. Manisha ma'am, you want to say something?
No, thank you. It was a wonderful session and a great initiative by WBSSP. So I hope it really helps the physicians as well as the patients. Thank you so much.
Dr. Weber,
please wrap up.
Yeah. I would like to extend my deepest gratitude to each of you for your exceptional contributions to our panel discussion. Your diverse expertise and insightful perspective have made this event a remarkable success. So thank you once again for your time, effort, and dedication. We look forward to future opportunities to collaborate and learn from your vast experience. Thank you very much, all the panelists. Okay, Dr. Abel wants to say something. Hello, please unmute yourself.
One of the speakers said, the blind men and the fibromyalgia extends much. What I have realized is that the fibromyalgia goes to different specialists are also different. And there are also regional differences. So, the proportion of subgroups in neurology practice may be different from a psychiatry or a pain clinic or a rheumatology. So if you really want to understand fibromyalgia, all these patients need to be pulled together and there must be greater dialogue. And just like the patient, there has to be a fibromyalgia interest group, which is multidisciplinary, which brings everybody together. Only then we can make further progress in this challenging thing, and then only we can help patients. We still don't know a lot about fibromyalgia.
Sir, to take
Sir, to take
your what you
your
have
what
just
you have
said
just said
forward,
forward,
I think we'll
I
have
think
a
we'll have a
proper
proper
scientific meeting,
scientific
not a
meeting, not a
public awareness
public awareness
program,
program,
and we
and
would
we
love
would
to
love to
have you on
have
board
you on
once
board once
again.
again.
With
With
these
these
words,
words, I would,
with
with
the
the
permission
permission
of
of
the
the
president,
president,
I'll
I'll
call
call
off
off
the meeting
the meeting
and close
and
it.
close it.
Thank you so very
Thank you
much,
so very much,
everybody.
everybody.
Thank you very much.
Thank you.